Hi, this is Professor O'Connor, and this is part 4 of your pre-class assignment. It is talking about croup and epiglottitis. There are many different forms of croup, and I'm going to actually talk about two today. The first one is croup LTB, or laryngotracheobronchitis. The etiology of this form is a very acute viral illness, and of which LTB is the most common. It occurs in children between the ages of 3 months to 3 years or 6 months to 6 years, and it peaks around 2 to 3 years. And it's boys more than girls that get it. Pathophysiology-wise, parainfluenza is the most common cause. It occurs in the fall and winter months. And influenza, RSV, or respiratory syncytial virus and mycoplasma can also cause it. These children have copious secretions and increased respiratory distress. Diagnostic procedures are done by history and clinical signs. Throat culture and visual inspection are contraindicated, as it may cause the child to have an airway obstruction. Radiographic studies may show a subglottic narrowing, which is known as the steeple sign, and pulse oximetry will show hypoxemia. Signs and symptoms of the assessment findings. The child would have had an upper respiratory infection for a couple of days prior to developing croup. It would progress to cough and hoarseness. Fever may or may not have. Tachypnea, inspiratory stridor, which is completely upper airway occlusion, and seal-like barking cough, which is unique to croup. Medical treatment is aimed at maintaining and improving respiratory effort with medications and oxygen. The child would receive oxygen if the SpO2 is less than 92%. The child can be treated at home if it's a mild case. Usually they'll be placed on corticosteroids by mouth, and recent information and studies have shown that no cool mist, so placing them in a room with a shower on really doesn't help anymore. If the child is hospitalized, they will receive nebulized racemic epinephrine, which only works on the upper airway. They will receive corticosteroids, usually intravenously at the beginning, and then as their PO intake increases, they will switch to by mouth. They may receive nebulized budesonide, and they may need intensive care unit and intubation if they develop laryngospasms. There are 2 YouTube clips here that you should view. They are also placed in the document where all of these screencasts are, so you can either pause this and view them, or you can view them separately after you have seen this little screencast. The first one is a baby with croup, and the second one is stridor and retractions. There is a third video clip, and this video clip shows you the difference between bronchiolitis, which affects the lower airway, and croup, which affects the upper airway. So please view this one also. For nursing assessment, note the age of the child, from anywhere from 3 months to 3 years or 6 months to 6 years. The difference is based on which materials you've read. It can be either of those. And that would be to present with the LTB croup. History may reveal a cough that developed overnight. That's the most common presentation. The cough sounds like a barking sea lion. Inspect for presence of mild upper respiratory infection symptoms. The temperature may be normal or mildly elevated. Listen for inspiratory stridor. That's that upper airway noise. Observe for substernal retractions. Auscultate the lungs for adequacy of breath sounds. The diagnosis is usually based on history and clinical presentation, because you are not going to be putting anything into the mouth, which may cause obstruction of the airway. They may do an X-ray, which would reveal a steeple sign, and that would also be used to rule out epiglottitis, which I will be talking about very shortly. For nursing management, the children who have a mild case and can be treated at home, we want to make sure that the parents understand to keep the child quiet and discourage crying. Allow the child to sit up and maybe sit in the parent's arms or on their lap. Encourage fluid intake. Recent studies do show that a steamy shower is no longer helpful. Administer corticosteroids if it's ordered, and when to call the doctor. They would need to call the healthcare practitioner if the child is breathing faster, has retractions or difficulty breathing, if they have nasal flaring, the lips or nails have a bluish tint, There is a cough or stridor that does not improve. There is restlessness increasing, or the child is confused, or the child begins to drool and cannot swallow. If the child is treated in the hospital, our main goal is to keep the airway open, and to do that we want to keep the child calm. So that may mean the child sitting in mom's lap. Oxygen saturation should be on at all times, and we would administer oxygen to keep the O2 sat greater than 93%. We're also going to administer medications. Those medications are nebulized racemic epinephrine, corticosteroids, IV first, and then going to PO as they increase their PO intake. And we want to keep them well hydrated. So if they're not taking PO, they may need IV fluids first. At this point, I'm beginning on the second form of croup that we'll be talking about, which is epiglottitis. Epiglottitis is an inflammation or swelling of the epiglottis. It's caused by the Haemophilus influenza type B bacteria. And the Hib vaccine that we administer to infants and toddlers has made this a very rare occurrence. However, when it does occur, it occurs in children between 2 and 7 years of age. It can be life-threatening, and treatment is going to focus on airway management and antibiotic administration. It does require an intensive care unit stay. Assessment findings: you're going to see a child who is sitting almost in a tripod position with the chin out, mouth open, and tongue protruding, and this is a very classic sign of epiglottitis. You will also see the 4 Ds, which is classic to epiglottitis: drooling, dysphonia, dysphagia, and dyspnea. They will have a toxic appearance, and they may have or may not have a mild upper respiratory infection preceding the illness. It has a very rapid onset, occurring within hours. The child develops a very high fever. They have inspiratory stridor, a sore throat, and restlessness. Our nursing interventions are first and foremost to never, ever, ever leave the child alone. We want to allow the child to sit up, no supine position. We want to protect the airway. No throat culture or tongue blade is to be used. We want to prepare for intubation, so intubation equipment should be ready at the bedside. We want to provide humidified oxygen in the least invasive manner. Pulse oximetry should be on at all times. We'll be administering racemic epinephrine by nebulizer, corticosteroids IV, and IV fluids. We'll also be starting antibiotics, and it's usually ceftriaxone, and it'll start IV and then switch to PO until they finish a 10-day course. We want to provide support to the parents as well as the child. This is a very frightening illness for the child and for the parents, so we need to make sure that we provide support. The last of our nursing interventions for epiglottitis are to keep the child as calm as possible. They can occlude their airway anytime prior to intubation. The goal is to get them endotracheally intubated, but if that doesn't occur and they obstruct completely, then you have to prepare for a tracheostomy. So you have to have the intubation equipment nearby, and you have to have a qualified personnel ready to perform that tracheostomy at a moment's notice, so they need to be nearby. This is the end of part 4. Please go to part 5, and thank you for your attention.